Another type of long-term vascular access device is a portacath, or an implanted port. One type of portacath or implanted port is called a power port. These are used for individuals who need typically a CT scan with contrast frequently, and so the contrast is injected at high power, and this port is able to withstand that pressure. You don't treat that port any differently. So for all portacaths, LPNs and RNs at Accurate Home Care, again following your state's scope of practice, may access the port if properly trained. Ports are accessed with a non-coring needle, or a Huber needle. They have a self-sealing septum which is seated in the subcutaneous tissue, and they're intended to be left in place long-term, but not recommended for long-term continuous therapy. They're accessed, as I said, with that Huber needle. This is kind of what a Huber needle looks like, and so if you pay attention to the bevel on the needle here, it looks like it's curved, but in reality the opening of the needle is on the side, the straight side here, as opposed to on the slant like most needles are. And so what that does is effectively creates a slit in the septum instead of a hole. So typically a needle that goes into the skin will take out a very small core of tissue along with the injection. But this needle, again, actually just creates one narrow slice through the septum, and then the septum is able to close up and seal again. So portacaths are accessed just when the IV therapies are indicated. They can be accessed for up to 1 week, but then the device needs to be replaced. So the Huber needle that's used to access the port needs to be replaced once a week. Sterile technique is used when accessing a port. And if the device needs to remain in place, then you're going to use a sterile transparent dressing like a Tegaderm to cover the port. Ports can be used for blood draws, and most surgeons say that a port can last anywhere from 2 to 6 years, but can be accessed up to 2,000 times. So again, definitely intended for long term. When the port's not being used, it's accessed and flushed monthly with normal saline and or heparin. And so that's something that we frequently do in the home, is this monthly access of ports. After blood draws, you also need to flush with normal saline and heparin, and the needle needs to be changed after a blood draw. If you're getting resistance or you can't get a blood return with a port, ports are very positional, and so it's really important to reposition your patient. If the port is on the side of their chest, have them turn their head in the opposite direction. They can raise and lower that arm, they can sit up, they can lay back, they can bear down, perform a Valsalva maneuver. That will a lot of times help to clear up the obstruction, because again, it's usually positional. So definitely do some troubleshooting with a portacath. If the needle is in the septum, you don't need to do any repositioning of the needle. Again, so repositioning the patient is usually the most effective way to get a portacath to work. Catheter skin site needs to be visible to be inspected through the intact dressing, so of course that's why we use Tegaderm. A sterile dressing is applied and maintained on access devices, and then we're going to follow that 7-day regimen for changing dressings. And there's a separate video that goes through access and de-access of the portacath. There is an Elsevier video that reviews troubleshooting of centrally implanted or centrally placed catheters. However, there's just a couple of additional complications that I wanted to review. An embolism. So an air embolism is actually the most common, usually caused by the catheter breaking off. We can also do our best to prevent that by making sure that all tubing is primed and syringes have air removed prior to use. Signs and symptoms of an air embolism or any type of embolism are chest pain, shortness of breath, hypotension, and apprehension. Patients have described just this feeling of impending doom. So interventions in this situation, this is an emergency, you would call 911. Lie the patient left side down. That's hopefully going to trap the embolism in the heart so that it doesn't travel to the brain, and certainly notify the physician. Infection is caused by improper site care if it happens at the site, or there's also something called a port pocket. So with a portacath, if you're using port technique, so not cleansing the site thoroughly, not using sterile needles, things like that, you can develop what's called a port pocket, so a pocket of infection between the port itself and the skin, so in that subcutaneous layer. Again, only caused by poor technique with access, so definitely something that's preventable. Contamination of equipment and poor aseptic technique are the main causes of infection with central lines. Again, something that we can absolutely work to prevent. Our number one job when our patients have lines in home care is to prevent infection. Signs and symptoms of infection: redness, swelling, drainage. We may need to consider more frequent dressing changes. Perhaps the patient has a skin flora that's present, and we can prevent infection then by cleansing the skin more thoroughly or more frequently. Notify the physician and monitor for systemic infection. So if we've moved beyond a site infection or a port pocket infection and now we're moving toward a catheter-related bloodstream infection. This is caused by insertion if it happens within the first 24 hours, but otherwise it can be caused by a lot of different things. Skin organisms, the hub or the cap that's on the line, the infusate itself if that is contaminated. Could be of a homogeneous origin. What we're going to see with our patients is fever, chills, malaise, headache, just that general sick feeling. We need to notify the physician right away. We need to reinforce the importance of good hand hygiene. As I said, infection is our #1 enemy in home care with patients who have lines, and we can prevent that. Prepare the patient. If they have a catheter-related bloodstream infection, they're likely going to have that line removed. Anytime you're working with any type of central line or peripheral IV or PICC line, you need to complete proper documentation. Components of that include, of course, writing legibly, including factors relating to assessments, interventions, and most importantly, your patient's response. So make sure you're always documenting the insertion site. So where is the line placed and what is the integrity of the insertion site, the type of the access device and the number of lumens, the site condition and the appearance, complications that arose, and any site care that you performed. IV therapies must be initiated upon the order of a physician. As always, you can accept verbal orders, but they need to be signed by the physician, so sent in to Accurate following our documentation guidelines. It's your responsibility as the nurse obtaining the order to verify the order and make sure it contains all of the rights of medication administration. You also need to recognize the appropriateness and the accuracy of the prescribed therapy. You're the one who's giving the medication, and so you need to make sure you understand why and if it's safe for the patient. And of course, have knowledge of and accept only abbreviations approved by Accurate. So that includes orders with medications in their unit dose and listing generic names of the drugs as well. It's important to always be providing education to our patients, but especially important when there are intravenous lines in place. Educate the patient, educate the caregivers, and document the education that you've given. The client education should include using clear and concise terminology so that patients can understand, why do I have this line? What do I hope that it will do for me? What should I be watching for? And when am I going to be finished with this? So I've already mentioned the importance of infection prevention when our patients have lines at home, and the #1 way to prevent infection is hand washing. So hand hygiene is incredibly important with central lines. Also important to do proper nail care, and remember that no artificial nails or nail products should be worn while you are working with patients at Accurate Home Care. You may use an alcohol-based hand rub. We don't want to use that more than about 3 times in a row, and certainly never using alcohol-based hand rubs if our patients have a diagnosis of Clostridium difficile or C. diff. That alcohol-based hand rub doesn't kill C. diff. Bar soap should not be used. Bar soap really harbors bacteria, and sometimes we have a component of patient education with that as well. So just remember not to use bar soap. You should use liquid soap. Educate your patient and family, document that education, and if there's still a concern with it, reach out to your supervisor. Scrub the hub, so scrubbing that cap prior to access, maybe during that sash technique. Scrubbing with an alcohol wipe with using friction, so really solid friction. We're not just wiping the tip a little bit, we're using solid friction and scrubbing for 30 seconds is our recommendation. 5 seconds is a minimum. So again, longer than you think, and use that time to provide education to the patient on why that's important. Nurses need to wear gloves with all procedures. It doesn't matter how well you know the patient. It doesn't matter if you've never seen blood coming out of their line. You have the potential for exposure to blood, and so you need to be wearing gloves anytime you're working with a central line. It's important to always maintain sterile technique as well. If at any point you feel that your sterile technique has been compromised, start over. It's easier to start over than to treat your patient for an infection. DME should be disinfected according to guidelines. So make sure that you're following the recommendations, and if you have any questions about that, reach out to your supervisor or the DME provider. Sharps need to be disposed of in a non-permeable, puncture-resistant, tamper-proof biohazard container. Our patients don't always have those at home, so what else could we use? You could actually use something like a laundry detergent bottle or a fabric softener bottle. Those have a smaller top and they have a top that screws on. Some people have suggested a coffee can. That's not ideal because the opening on the top of a coffee can is very large, and so there's a potential for contamination when that gets opened. So something with a thicker plastic and a small top that screws on is appropriate. Milk jugs are usually a little bit too thin of plastic. So using a laundry detergent bottle and marking the outside of it as biohazard is an effective option. And then remembering that when that container is about 3/4 full, you should be disposing of it. We don't want to try to cram those as full as we can. So close it, tape it up again, and it actually can be placed into the household trash. Obviously, it's ideal to use Sharps containers and disposal services, but that is a home option for our patients as well. Remember, when you're working with all medications, but in particular IV medications, you can't administer medications beyond their expiration date. Make sure that the manufacturer's label is followed in terms of storage. If the medication should be stored in the refrigerator, then it needs to be stored in the refrigerator. If it's not stored appropriately, that expiration date may not be valid. You can always reach out to the pharmacist if you need clarification on that. Another item to note, scissors should not be used in the presence of vascular access devices. The only time that you would use scissors is for suture removal. So if you have an order to remove sutures, be sure that you feel comfortable doing that. If you're someone who doesn't have great vision up close, or who maybe doesn't have a real steady hand, don't do it. It's not worth the risk. Let the patient and the family know that it's too risky for you to do this, that you'd rather have someone else complete it who can see more fine detail or who can hold still enough to not run the risk of damaging the line. So never using scissors to remove dressings or tapes or stabilization devices. And that concludes our training on central line. Be sure to complete any other videos, tests, and your skills checkoff. Thank you.